a blood clot, of a fresh blood clot. And two things are problematic there. It stretches the vein as the blood clot grows, and it also impedes the flow from the foot or the calf or the lower leg back up to the heart. And with that impediment of flow, you're going to start to get swelling. And that's one of the key symptoms of a DVT is swelling or edema of a single leg. Very, very seldom do we see both legs being affected at the same time and both legs swelling. So it's usually unilateral edema or swelling. Also associated with that is pain, calf tenderness, or even if it's more extensive, the whole leg is affected, and then along with that swelling pain, also redness or discoloration that looks somewhat like almost a cellulitis of the lower extremity. So those are the three big things. Now there are a lot of other subtle issues that we can get more involved with, but the key is swelling, pain, and redness of usually one leg as opposed to both.
Classic manifestations. So practically anybody that has had an injury or otherwise out of the blue, if it crops up on them,
right,
and just kind of a streaking of this lower limb, sudden swelling, and a lot of throbbing discomfort of the lower extremity in the calf and the thigh area has to raise a suspicion instantaneously.
And DVTs, you know, we harped on a lot about hospital patients, but DVTs are actually just as common in the outpatient situation too. So I'm stressing that to the audience to be aware of that.
Absolutely.
It's not just a hospital-based type of problem.
It looks like we have a first caller already in the show, Jenny from Opelousas in line 1.
Hello, Jenny.
Yes.
Thank you for calling. You have a question?
Yes, sir. Last year I went to CIS for my stress test, but my mom died with a heart attack when she was 74. My dad died at 49 years old. What is my risk? I'm 48. And sometimes I just get stressed out. I just feel real stressed. Right now, my daughter has been sleeping at night, and I feel stressed. What your advice to?
Sure. Okay.
Okay.
Well, the question is that Jenny, as a strong family history of heart problems, she's approaching that somewhere of the mid area, somewhere about 50 years, and she's concerned about her own risk of heart disease. And I'll quickly address this. Here, she's about 50. She has strong family history. As we keep on reiterating this in all our shows, anybody who's approaching it, and of course, if she has diabetes, she has high blood pressure, high cholesterol, family history, be it siblings or parents having heart problems, will put her on an extremely high risk of possible heart disease. And if she's also a smoker, and if you're not in the greatest of the physical conditions and you're inactive, and if your cholesterol is high,
and postmenopausal.
and you're approaching that menopausal period where your risk starts catching up with that of the risk of men, which is usually higher than women in the premenopausal state. So she has to have a high degree of suspicion and have some basic checkups. First, as simple as having EKG done, checking her rhythm, checking for any thickening of the heart muscle, checking her blood pressure, checking her cholesterol. If any of those are abnormal, we have talked about CT calcium scoring these days has emerged or is emerging, continuing to emerge as a very strong risk assessment tool where you check for hardening of the arteries by a simple outpatient test which takes less than 10 minutes, and if there is a lot of hardening, that raises the red flags, and then we can go further. Of course, if she doesn't have any symptoms, there is no great indication to go on and do treadmills and other things.
Right.
But if she has a high calcium score, then we can justify to walk her on a treadmill and see how her heart responds, what kind of EKG changes does she have, and then also do nuclear imaging, which can show any reversible defects in the heart muscle, which can raise red flags to presence of blockages. So I think that would be the basic format of approaching Jenny's question. And let us just revert back to our discussion here. Clay just you elaborated on diagnosis of or the clinical presentation of deep vein thrombosis. And the next slide, we'll just divide it and talk about PE. But Fernando, can you please shed some light on what are the diagnostic tools once you start suspecting that there is deep vein thrombosis by your clinical examination and physical examination of the patients? How do you go about objectively establishing the diagnosis?
That's extremely simple, and a simple test. It's an ultrasound, a venous Doppler ultrasound to look for these clots. Now, it's not perfect because when you get up into the pelvis, you really can't see it too well. The only thing that would be better than that would be to do a venogram, and then you're able to demonstrate where along that vein you're going to have that problem. But simply, and what we use most frequently is a venous Doppler.
So that's really a kind of very simple straightforward. Historically, it's been done for decades, and it still remains the cornerstone of diagnostic tool for diagnosing venous thromboembolism. And certainly, when in doubt, you can do a CT venogram. Now, let us just kind of take a step forward and jump into the other big consequence, short-term consequence, which we are talking about, the PE or clots to the lungs. And we all know that once there is extensive DVT, all the veins draining from the legs all the way through the pelvis, this leads on to the right side of the heart that then drains into the pulmonary arteries. So if there is a large piece of clot that is undiagnosed, unchecked, there is a tendency for it to break loose and migrate upwards into the slowly, gradually in the bloodstream and lodge in the lungs. And depending on the size of the clot or the suddenness of the clot, the consequences can be variable. Can you talk a little bit about the short-term presentation of pulmonary embolism or clots in the lungs?
I'll take that. As you can imagine, all the blood in the body has to flow from the heart through the lungs. So there's a massive amount of blood and a volume that flows through that lung artery. So any obstruction of that is going to be exploited and almost logarithmically enlarged by just the sheer amount of volume that goes through there. So it doesn't take much blood clot to become to have a symptom or to cause problems. And blood clots in the lung can be, you've got to think about the lung artery or the vessels in the lung is kind of like this. You've got a main artery that comes into the lung and then starts branching out into the different segments. And depending on the size of the blood clot that actually goes through the pulmonary artery, if it's very large, it'll stop here and then the whole downstream part will be affected. However, if it's small, it may just go out and lodge at the end of a small vessel. So the amount of damage or the effect of a pulmonary embolus is extremely determinant on the size of the embolus to start with. So obviously, if it's very large and affecting the whole side of a lung, and that's 50% of the blood flow right there, and so a patient's going to be very symptomatic from that, and it usually happens very suddenly. And in this sort of case, is not a gradual, insidious onset. The smaller ones sometimes very small ones are asymptomatic and only picked up, from workups of chronic shortness of breath and things like that, trying to figure out what's going on in a patient with those sorts of complaints. But so you can have anywhere from a very large partial obstruction or even a minor ones in the lungs. Some of the symptoms other than shortness of breath, chest pain. It's very common to have chest pain, and it's fairly nondescript. Sometimes it's sharp, sometimes it's pleuritic, meaning it hurts when you breathe. Sometimes it's pressure and tightness that leads us to think more maybe it's heart and heart attack. So the chest pain syndrome is not very descriptive. It does raise flags, as Dr. Farina was saying, that tells us that we need to look. But there's no certain type of chest pain with a pulmonary embolus that tells us that it's to distinguish a pulmonary embolism from, say, a heart attack or something like that. So The shortness of breath and the chest pain are the two key
Absolutely.
elements.
There's one other one I kind of want to mention, the cough.
Cough.
You can have a cough, and the cough
Right.
can
I'll
have
settle
blood in the cough or blood-tinged sputum.
Hemoptysis or
Right.
And
coughing
that's
up blood. If it is
correct.
massive enough, you're basically infarcting or killing, in a way, temporary death of the cells within the area affected by the clot,
Downstream
thereby
from the clot.
coming out when you're coughing.
Kinda
And of
like a
course,
lung
when
attack.
it's massive enough, it can lead to hemodynamic collapse.
Correct.
Or sudden precipitous drop in the blood pressure, which can be completely refractory to any form of intervention when it's massive enough. But
That's
of
when we
course,
see the
even
sudden
one
death.
side is affected. It can. So that then brings to our discussion of in-house sudden cardiac death, in unexplained sudden
Correct.
cardiac death in-house, sudden death where the patient cannot be resuscitated by any means.
Which I didn't talk about the saddle
Yeah.
embolus, but that's,
Oddly
but-
enough, even patients with heart attacks will give us some time to operate, even if they're having a massive heart attack. The blood is still being pumped by the heart, whereas if a large piece of clot ends up in the pulmonary artery, if it is
Clots all
so-called
flow.
saddle embolus or
Both
a
sides.
massive embolus spreading like fronds into both of the lungs, as you just discussed, there is not a drop of blood, or very few drops of blood are going into the whole arterial system to the heart to be pumped into the rest of the circulation. So that causes sudden precipitous drop. And no matter what you do, if you cannot get that blood into the left side of the heart to be pumped to the brain and other organs, and it'll result in hemodynamic collapse and death. So it is quite dramatic in those circumstances when there is massive PE. But thankfully, we do get a chance to diagnose them. And I think as the diagnostic modalities, as our education evolved in the past 2, 3, 4 decades in diagnosing PE, we have really made great strides. But I think going back to the treatment, I guess we still did not make as many strides in treatment of pulmonary embolism
Right.
We don't.
or
We
DVT
don't.
for that matter.
Correct.
But let us just kind of take a step back and talk about diagnosis of pulmonary embolism. I think historically, people have done ventilation perfusion scans. Once the clinical history and your clinical examination is highly suspicious for deep vein thrombosis, then we can go on and get into diagnostic modalities. A lot of times patients can be extremely sick in the emergency room, and if you're working and if you do a blood test of a D-dimer or other such tests, and if their oxygen saturation is low, and if they have a clot in the leg vein by ultrasound, that in itself is proof that the patient may be having pulmonary embolus. We can treat them presumptively because the beginning of these treatments most times involves treatment with blood thinners. So we can start the treatment before we transfer this patient and confirm the diagnosis. If they're stable enough, we can do the so-called ventilation perfusion scan, which is done in the radiology department, but patients who are sick may not be able to cooperate to do a ventilation perfusion scan. But I think as time went by, CTA of the pulmonary arteries, especially with the new ultra-fast CT scans, 64 or higher slice CTs, appear to be remarkably sensitive in picking up the smallest of the pulmonary emboli instantaneously, and it is done with a large bolus of contrast in the peripheral IV, and in 10-15 minutes you have the complete diagnosis, so you can go on a treatment path. So really, I can't think of a whole lot of other, certainly echocardiogram, if you don't have these
Initially,
modalities.
correct.
If
Well-
you do an echo, we can...
they're
Basically, in the emergency room, you're going to use the echo as a suggester.
Right.
When you do the echocardiogram in the immediate situation, you find that the right ventricle is enlarged, and you really don't have an explanation for it to be that enlarged, and you have a right atrium that's enlarged, you can assume that there is an elevated pressure in the pulmonary artery, and you can assume that there's a clot. Again, these are things like you do in the emergency room. The D-dimer tells you that there's a thrombotic event occurring,
Right.
but you don't know where it's happening nor what's causing it. It could be after a surgery, could have been after an infection, but it can be associated with it. It raises your suspicion. Where you want to be able to do is that CT scan. It's probably, for me, it's one of the gold standards. To do that CTA and see that clot inside the pulmonary arteries is, for me, the best option for that. If you can't do that, then I'll go off to the VQ scan, because the VQ scan requires them to breathe.
But
and it's more
cooperation of the patient.
But
absolutely.
everything is suggestive up until an angiogram.
Until you do the
Which
angiogram.
the old-fashioned way of doing an angiogram was to put a catheter in the leg or the jugular artery and put a catheter actually into the heart and put dye into the lung bed and look at it, and that's pretty invasive relative to what we can do with a CAT scan nowadays.